Welcome to the Phoenix Prosperity Podcast, where wealth meets legacy. Join your host, Tim Fergestad, as we explore the journeys of Phoenix's finest to success and beyond.
Hello, this is Tim Fergestad. Thank you for joining us. I'm very pleased to have Heidi Dalton with me here today. Heidi is the president of ECMO Virtual Advisors, professor of surgery at Creighton University. Welcome to the show, Heidi. I'm excited to talk a lot about this. Very interesting stuff.
Well, thanks very much for the invite. Glad to meet you and glad to talk to folks.
So for people who don't understand what extracorporeal membrane oxygenation is, can you explain ECMO and the whole heart-lung oxygenation, the blood bypass stuff?
Yeah, sure. So I've been doing this since I was a resident. I'm a pediatric intensivist by training, although I live mainly in the adult world these days. But this stuff is a modified form of cardiopulmonary bypass that we can put you on, where we drain blood out of a big vein in your body, and then we run it through a pump that acts like your heart. And then we have a membrane lung that acts like your lungs. It adds oxygen and takes out carbon dioxide, which is what you burn oxygen for as you make fuel to make your body run. And then we put this oxygenated blood back into your body. And the idea is that we can support your heart, your lungs, your other organs while they're either repairing themselves, or we can bridge you to a transplant like a heart or a lung transplant or whatever, or in the case of bad heart disease, we can keep you on ECMO for a little while and then decide that you need to have a more durable device, kind of like a ventricular assist device or whatever, placed. And I've been doing this since I was a resident, but ever since the H1N1 days, it's become very popular in the adult world, which had sort of always shunned it. It always had been used in infants and children in the past. And so I've started many programs throughout the world, and I do a lot of education and such. And I'd been functioning as the chief of critical care at Phoenix Children's when I first moved out here. I did that for a while. And then I was recruited back to Northern Virginia, where I spent most of my career in DC, helped them build their ECMO program over the last few years. And people were always calling me and asking for advice. And finally, some of my friends are like, well, why don't you start a company, because you're giving all this free advice.
Right.
And
you're consulting already.
Yeah. So I started this company, ECLS Virtual Advisors, a couple of years ago with some of my colleagues. And we provide virtual oversight of patients at centers that are either starting ECMO or branching out, or who just need virtual help. And then I do a lot of education and training, and then I work a lot with industry, because this is sort of a niche area where you need industry involvement to move the field forward. So I work a lot with industry to help design new devices and help get them brought to market. And then I do a fair bit of research. My particular area of interest is eliminating bleeding and thrombosis, which is the major complication of this ECMO stuff, because since you're taking the blood out of the body, it will clot in the plastic. Yeah, you put people on. Yeah, that's right. Yeah, so I'm trying to figure all that out.
Okay. Before we get into the how ECMO has changed over the years and stuff, can just a few more basic questions. How long can somebody be on ECMO?
Well, it used to be, when I first started, it was like 2 weeks or less because of all the complications from the machine. Okay. Now we know with some of the more advanced technology, people have actually been on for over a year.
Wow.
A lot of those types of patients.
I didn't know that.
Yeah.
Okay.
Yeah, we never used to think that was realistic. And those are respiratory failure patients. But we always used to think that your lung couldn't repair itself, past about the age of 6, that you could not grow new lung tissue. And over the past few years, we figured out that, lo and behold, even if you're an adult, your lung can remodel. And since lung transplant, A, is there aren't enough lungs to go around, and B, of all the organs that we transplant, they last the shortest period of time, and they're fraught with complications. So now, actually, some people with respiratory failure have been on ECMO for even a year and have recovered lung function enough to get off. If you're a heart patient, normally you're not on ECMO for more than a couple of weeks, because Either they find some lesion that they can go in and repair in your heart,
Right.
or we can transition you to a ventricular assist device or
Okay.
whatever.
Okay. And yeah, correct me if I'm wrong. Like a lot of muscles, you don't want to stop using it and expect to use it more later, right?
Yeah, I mean, it's certainly for the heart. ECMO doesn't, it's not like bypass. Your heart is not completely unfilled with blood. It has some blood in it, and we want your heart to
Be
beat, although
perfused.
sometimes
Okay.
that doesn't happen, but we want your heart to beat some. And
Huh.
for your lungs, I mean, the idea is that most of the patients that go on for lung injury are on such high levels of mechanical ventilation, which we know is also inducing harm, that we're just adding more harm on top of what their underlying disease is. And so if you can put them on this device, you can turn a lot of that support down because you're doing all the work for them.
Okay. Right. Right. You mentioned that it was not very um, common in adults. Why was it? Is that just because the lungs you didn't think could
No,
recover?
actually, no. Actually, that was more based on the fact that back in the 70s, there was an NIH-sponsored trial that compared ECMO in adults to conventional mechanical ventilation. And they found that the survival in both arms of that study was like terrible. It was like 9% or something. And a lot of the ECMO patients, bled to death and, had many complications. But when you actually looked at the study, I mean, they used centers that had never done it before. The stuff that we used back then isn't nearly as efficient and safe as it is now. And so it's been used very successfully in infants and children. And then certainly when H1N1 came around and then COVID, healthy people were dying, from
Right.
respiratory failure, the flu. And so folks started using it. And the way a lot of things work in the world, things start over on the other side of the pond, like in Australia or something. And then we look at their results and decide if they're worthwhile or not. So those two events, plus the fact there have now been a couple of randomized trials in adults, again, of ECMO compared to conventional therapy, that have been positive in favor of ECMO, both in terms of survival and economics and stuff, has really
Okay.
caused this to be regenerated in the adult world.
Okay. So better studies and stuff, but can you talk a little bit about how the technology's changed as well over the years?
Yeah, so when I first started, we used these things called roller pumps, which were used in cardiopulmonary bypass as
Okay.
well. And they're very efficient at taking blood out of the body. You run it through a box with these roller pumps that pushes the blood forward. But
Yep.
by doing that, it generates a lot of high pressure. And
Mhm.
so that high pressure, if anything obstructs the flow of blood leaving the pump, it can cause the pump to blow up and there's blood all over the place and that sort of thing. And so you had to have someone sitting there all the time to emergently interact if something happened. And then the other thing was the membrane lung that we were using. Made, back in the 1960s, worked, but it was very high resistance. You had to change it out every couple of weeks at the most,
Right.
and it had a lot of complications with it. Now we have centrifugal pumps, which are safer and easier to use, and we have what they call hollow fiber oxygenators, which are made of these little tiny hollow fibers that gas can go across, and then the blood can exchange gas
Huh.
without across these fibers without actually touching the gas itself. And those things are very low resistance. They can last for weeks or months even. And
Okay.
those two events really have changed how ECMO is done.
Okay. Can you talk a little bit about the cost of that technology and how it's gone up or down over the years?
It's highly resource use, and it's highly expensive.
Okay.
There are a couple studies I mean, if you're a patient, transplant is still the most expensive thing that heart patients undergo. ECMO is sort of under that, but it is expensive. But if you figure that you can get somebody out of the hospital and they can have a good quality of life, return to the workforce, all of those types of things. The
Sure.
quality of life comparative effectiveness studies that have been done, at least with respiratory patients, show that it is financially viable in terms of the types of things that we consider, appropriate for quality of life, breast cancer, for instance, or other things. Most people say
Right.
$50,000 is a quality of life limit. So if you can get patients off and they're costing you less than that over time, that's a good use of your resources. Now, certainly with some of the changes that are coming in healthcare, I don't know how well that's going to pan out, but
Right.
there are a lot less complications than they used to have, although there are still, bleeding and thrombotic concerns that really prevent it from being used on everybody.
So was it historically also like emergent use and has turned into more chronic
Um,
use?
well, I would say the placement of patients on it has become shorter rather than we've tried everything we can think of. The patient is at death's door and we'll do this as a Hail Mary or whatever. So, people are becoming more ready to accept it as a supportive treatment further, without the patient necessarily being on death's door. One of the problems, though, is despite the fact people have done lots of work trying to come up with selection criteria, which are universally good, there aren't any. Every patient is different, and all the severity scores and stuff that we've come up with really haven't panned out when you actually look at bleeding and thrombosis and death and all that stuff. And so you can't use the scores that are out there for any individual patient, although they might help you with some prognostication, like when you're talking to families about whether to do this or not. But that's another reason why I think in this age of AI and big databases and all that stuff, now that we can actually get data real time, we may be able to refine some of our
Right.
ability to select patients more appropriately.
Okay. And is there a challenge to show value there for insurance purposes?
Oh, yeah. I mean, as I mentioned, it is expensive and it takes a lot of personnel. I mean, in most programs here in the States, you staff patients so that there is a nurse for the patient. And then there's also someone that's watching the machine and that sort of thing. So
Right.
that increases personnel costs. In some places, in Europe, for instance, they often use a nurse to do both the ECMO piece and the patient piece. But it depends on how stable your patient is and that sort of thing. And certainly, if you're a center that doesn't do this very often, then there's a lot of work being put in to keep people trained up to do it, who then, may not get to do it very often. So they, may not be that good at it or
Sure.
whatever. That's another reason I started this company, to help out centers like that so that they don't, make the mistakes the rest of us have already made.
Right. Right. Okay. Well, work personnel expenses are amongst the highest, particularly when it's chronic. That you said that some of the technologies allowed people to not have to sit and babysit the machine all day.
Yeah, or they'll be responsible for 4 or 5 people on the machine. The other thing that's really happened is, like in the old days, used to keep everybody paralyzed and sedated and bedridden and all that stuff. Now there's a big push to get people up and walking and keep them from being so deconditioned. And actually, I mean, we used to think, oh my God, this is crazy. All the cannulas will fall out and stuff, but we know that's not true. And so now people get up and they walk around. And,
Mhm.
another reason why I started this company is that if the number of patients keeps going up as it is now, especially with respiratory failure, and they're on for months and months at a time, you cannot have all those people in an ICU environment, which is very expensive and which you
Right.
need sicker people in. So I think those patients then are going to be moved to, step down units, or, maybe even you'll be doing this from home or something. But, the field is changing rapidly. But so far, I mean, this isn't standard of care in every single center. There are
Sure.
specialized centers that do it. And the latest sort of group that's being applied ECMO is applied to are those patients in cardiac arrest. So now there's this whole field called ECPR, or ECMO applied during active cardiac arrest. And that started in the hospital, and now that's being actually moved out of hospital arrest. Or, you may have seen, I don't know if you've ever seen any of these. There's videos of people in the Louvre, for instance, being placed on ECMO. You come from Minnesota, probably the most successful ECPR out of hospital program in the United States is in Minneapolis. But they spent, I don't know how many millions of dollars grant funded to train up all of the emergency response people and get their system all together. And now they have a mobile ICU and all of these things that make it easier to do.
How mobile is the ECMO equipment and the?
Oh, it's much better than it used to be. I mean, it used to be an act of God to move all this stuff, but now there's miniaturized stuff, and it's becoming, more and more miniaturized. I'm actually working with a company now to bring a new device to market because we don't have enough devices. And making it transportable is one of the goals.
So what's transportable? What's a mobile ECMO size? Is it like a walking around with a file cabinet?
Yeah, it would be about that size. I guess maybe a 2-drawer file cabinet, maybe.
Okay.
Yeah.
Okay.
And they're on wheels and that kind of stuff,
Sure. That's amazing because the membranes, the gas exchange, and the pumping with that level of quality and control, that's awesome.
But it is expensive. I mean, it's a niche thing for companies. So, there are 2 companies out there probably who make ECMO their primary thing. But in a lot of other big companies, it's sort of an offshoot of bypass or whatever. And certainly, the money is in cardiopulmonary bypass because you're going to do that on a lot more patients than you are place them on ECMO. And so some of the technology has sort of been stalled because nobody wants to put a lot of effort. And it takes a lot of effort to get things to market. Okay. Yeah.
Sure. So what are some of the bigger challenges for you with your consulting firm and the industry in general that you're trying to solve?
Well, one of the big things is just, getting out there and talking to the right people at centers. Like we've started a few programs. I just got back from teaching in Florida, another group to teach them how to do it and that sort of thing. But, getting our names out there and stuff, we're not very good at marketing, actually. I have been a big I've been involved with the Extracorporeal Life Support Organization, which is the largest organization that tracks these patients for a long time. So my name is kind of known there. So I do run around and speak a lot all over the world and that sort of business. But you have to convince people that having some folks with higher levels of expertise is worth the money because nobody works for free, and that's one of the major issues, I think. And as healthcare dollars become more stringent, I was just on a call earlier today with a hospital that the doctors there are all burned out because they've been doing so much ECMO and they feel like they don't have support and they don't have enough virtual support because they aren't calling us, that kind of stuff. So it'll be interesting to see over the next few years, what happens in this field. But I think a few years ago, people were not sure if it was going to last or not. But since these trials have come out and been positive and COVID, it really worked. I mean, it saved many people during COVID. And it's becoming accepted in more realms. I think our big fear is that it's going to become standard of care for CPR, and then everybody's going to have to be able to do it, which will be a big stretch.
Why is that a fear?
Well, because there aren't that many people that are trained, that are experts. We don't have enough equipment, that sort of thing. But I think if that becomes a reality, I mean, obviously you'll see things ramp up quite a bit. But, a lot of the equipment that you use for this, it's not like it's automated. It's not like you can go to Ford or GM or something and say, hey, add us 100,000 extra widgets today. A lot of this is all done by hand. These membrane lungs, I mean, people stand there and actually stack these membranes to make the thing. And so it takes a lot of human effort. You can't ramp up that quickly.
Why is the incidence of respiratory issues increasing in people?
Uh, well, I'm not. Well, I mean, I'm not sure
I thought
it's.
that you
It
had
is
said something to that
increasing. I
effect.
mean,
Yeah.
you have viruses that come around. We have more elderly people around who have COPD, smoking, all these other things. And since we've gotten better with supporting patients, there are a lot of patients that we used to just completely exclude, trauma patients or pregnant patients. Like we've done pregnant patients, we've delivered babies on this type of support and stuff. So there are a lot of new groups that people used to think, oh no, we can't do this on because they're all going to bleed to death or they're all going to die. Even cancer. I mean, we have pretty good luck with cancer patients. Not patients that are at death's door, but certainly we've diagnosed cancer on patients. We've started chemotherapy on patients that are on ECMO with new cancer and gotten them off and that sort of thing. So, the realm of patients that you can do it on now is probably much different than what we did 20 years ago.
Okay. Right. Right. And well, how many, as it's gotten more effective and more widely used, you must have a lot of really good numbers on how many lives it's saved.
Well, if you look at the ELSO registry, which again is the largest registry we have, but it's a voluntary registry, so not everybody submits data. And even if you're a member of ELSO, not everybody submits all their data. They only submit their good data. But
Oh,
it is the
okay.
largest registry, and it has about 300,000 patients in it now,
Wow.
worldwide, most of it from the United States here. And if you look at the survival for respiratory failure patients is about 56%. That's true for adults and kids. The survival for cardiac patients is about 49%. And then this ECPR group, this people being put on during cardiac arrest, their overall survival is about 36 or 37%. And you may think, wow, that's not very good. But if you figure if you didn't put them on, it would be zero.
Right. Right.
It's not that bad. One of the things that we're focusing on now is in the past, everybody has looked at survival. Now we want to know survival with good neurologic outcome. And
Okay.
there hasn't been much funding to follow these patients out, after they go home and that sort of thing. And that's a real big need because we want to make sure as we're expanding its use, that we're not just creating, people that are
Right.
debilitated.
Right. Well, you had a lot of good results there, and you said you guys aren't good at marketing your stuff. Uh, I've noticed that physicians are always they're so smart and so good at so many things, but they're not great at everything all the time, right? And business is one of those things where I mean, some physicians are just crazy overachieving rock stars that they run out of the OR after their surgery and go summit Kilimanjaro on the next day, and then they sell their business the next day and do all that. But for the most part, a lot of people to be that good at what doctors do, it's hard to branch out and also run a business. What have the challenges been there for you, and what
Well,
have
it's
you learned?
interesting. It's interesting. I've been a chief at quite a few very large children's hospitals and have, with a lot of people that work for me in huge divisions and that kind of stuff. And actually, you know what? I did pretty well there. But when it's your own business, it's like, it's all these wimpy things that I don't like to do. I'm bad at keeping my receipts. I'm bad at,
Right.
I'm bad at, keeping everything up to date. And, we haven't spent a lot of money on a business manager or, anything like that. We're sort of doing it. We're doing it ourselves. And I'm a great idea person and I'm a, pretty hard worker and that sort of thing. But
Okay.
I would much rather be out taking care of patients and teaching
Sure.
than I would be, doing the taxes and that kind of stuff.
Sure. Sure. Sitting down with the CFO to,
Yeah, yeah,
yeah,
that's right.
yawn. Okay. Okay. Are there any misconceptions about ECMO? People think of it as just bypass or something like that you want to distinguish? Anything?
Yeah, I mean, well, I think a lot of people don't know what it is because it's not that popular, in the mainstream, although it is becoming more popular. People can look it up and see on the websites or see on AI or whatever what it is. But, I think there is this perception that it is just like cardiopulmonary bypass, which it's not. It's different, and how you handle the patients and take care of them is different. There well, we haven't gotten here yet, but in some areas of the world, uh, people are now coming into the ER and saying, "Well, I want ECMO." Well, you know, we're not quite there yet. I mean, there
Wow.
is quite a selection process, and it is still a sort of physician-controlled environment because, to the average person, I don't think they know a heck of a lot uh, about it. And because of the fact that it requires a lot of specialized training and specialized equipment and all of those other things, a lot of centers, choose not to do it, or they don't think they're going to have enough patient volume.
To
So,
justify it, right?
yeah, to justify it. So it just doesn't get done.
Okay. What are some of the bigger goals for your company at this point?
Well, we want to expand our footprint. We want to be able to help more patients, and we want to be able to help patients globally. I just got back from Latin America, where they have, a big need down there for folks to help them, but they don't have any money. So you have to decide how much of this is a business that you can be fiscally responsible for. And I think our goal over the next few years here is just expand our footprint, not only in helping other hospitals, but helping to make consortiums of hospitals. Because if you look at some of the big hospital networks now, a lot of hospitals are becoming consolidated, right? You have Kaiser, you have Common Spirit, you have Tenet, you have these big groups, HCA. And one of the problems with ECMO in the past has been that everybody does it the way they want. And I think one of the reasons why we haven't answered a lot of the questions, like what's the best anticoagulation regimen? What is the best transfusion trigger for blood products? Is because if I do it totally different than you do, my data and your data are never going to match.
Sure. Sure.
So we are working with some companies that you can stream data from every device the patient is on and that sort of thing, and their medical record, to try and figure out what is best practice, standardize that, roll it out to some more centers. Is it really best practice? What do we need to refine? And I think for the next few years, that's one of the things that I would really like to see focused on, because we have not been able to answer some, especially around anticoagulation, for instance. Lots of people doing lots of work, but really no good answers out there. And I think only by standardizing some of this care are those things going to be fixed.
Right. Right. Okay. Okay. Very interesting. Um, Here's a new question I'm starting to ask people, and I think so. My wife's done things in other countries, like kind of like you just mentioned, Doctors Without Borders and stuff, and
Hmm.
she's done procedures in Africa, but uh, and the facilities and the equipment are nowhere near what we're used to here in the U.S. I imagine ECMO is not an option in a lot of places like that. Is it generally big city facility, urban environments?
It is mainly big city urban environments. I mean, certainly one of the things, and I'm sure your wife would agree with this, is if you travel around the world at all, the disparity in healthcare is, ridiculous.
Right.
And I just got back from Brazil. Well, they had people in the public health hospital on ECMO, but they weren't using the best equipment. They were using some cobbled together stuff because that's all they could afford. If you go to the private hospital, it's like the Ritz, and you can get anything you want.
Hmm.
So I think a lot of us do have this vision, especially as stuff becomes more miniaturized and easier to put together, and you get some companies that are really focused on ECMO as their only goal, that hopefully will be able to overcome some of those disparities that certainly exist right now, even in the States. I mean, you can't get this everywhere in the States either.
Okay. Right. Right. So, but these are very meaningful and impactful things you've done. What have you done in the last 12 months that has changed your life?
changed my life.
Yeah.
Changed my life. Well, I've become more involved in this company. I'm certainly doing more. Well, I've always educated. I've started a hospital from scratch who's done
Oh
a pretty
boy.
good job. ECMO program, not a hospital, ECMO
Okay.
program. And that actually has been an exercise in how much culture in an institution can influence outcomes and patient care. And that's been kind of an eye opener because this has been quite a journey for them. But um, I think that's one thing. The other thing is that I've sort of transitioned away from bedside clinical medicine, which I've always done, to now being, the overseer, which is a
Right.
little bit different. I still like to do procedures. I still like to take care of patients. But over the last year, really, I used to go to Alaska and work in an ICU for 6 weeks a year that one of my fellows ran. And, I was an intensivist at multiple other places as well. But I've walked away from the bedside. And while
Okay.
that's been great for my lifestyle. I don't have to go in on the weekends and stuff. I am
Right.
available 24/7 and people call me 24/7. But not training fellows, residents and all that stuff has been a little bit of a change.
That's I like to sometimes ask guests about their legacy plans. You're in a place where you training people. You already have a big legacy of all the work you've done and all the people you've trained and so forth. Um, Generationally speaking, even too, because they're training and you're continuing on the movement, ECMO training. Um, do you have how long you been in Phoenix? Several years, right?
Actually, no, we came here in
2009.
2009, I think.
Okay. Okay. So would have
Or
you been
2016. Sorry, 2016, I think we came here.
okay?
Sorry.
Okay. Uh, Local impact? Have you grown some roots here in some of the different facilities and hospitals and community?
Well, certainly when I was at Phoenix, I certainly helped them develop their ECMO program. I
Okay.
helped, Dignity and Banner develop their adult programs during the time I was a chief at Phoenix. And right now I'm working with Mayo. We're working on a grant together. And I've become a professor of surgery at Creighton because I didn't realize Creighton had such a large footprint in Phoenix, actually, until the
Yeah,
last year.
yeah, I recently found that out too.
Yeah. So I'm trying to help them get their research kickstarted here in the Valley
Okay.
as well. And then I work with some of the folks around the region because we don't, for instance, have a regional ECPR program at all because it's hard to get people to all play in the same sandbox. So now that I'm an objective person outside,
Right.
I'm sort of trying to bring that
Okay.
into light as well.
Excellent. You enjoy that?
Yeah, it's good. My husband thinks I'm working harder than when I was a chief, but most of it is self-inflicted and it's from my couch or my house or whatever, but
Right.
it's good.
Okay. Excellent. Excellent. Okay. As we wrap things up here, what do you wish you knew about building wealth and success earlier in your career?
Well, I guess I was a, I guess I was a, I wish I was a better negotiator. I wasn't always a real good negotiator with my salaries and stuff. But I
Oh,
would
okay.
say that we've done quite well, mainly because we lived within our means and we didn't always have to have you know, I didn't go out and buy an Aston Martin or, whatever,
Right.
and I do think that
Which is a common problem for high income earners, right? That the expense or lifestyle creep, right?
lifestyle creep, and I'm not saying I don't have it. We live in a beautiful place. We belong to this fancy golf club, I do have a Porsche, whatever. But, we have been very fiscally, I think, responsible, and we've certainly
Nice.
tried to pass that on to our son and that sort of thing. I was not very good at investing, so we have all our investments done by a company that we've done quite well with and that sort of thing. But
Excellent.
I do think doctors don't get enough education in business, how to be a
Oh
good
no.
business person. And I think
They need so much education and other stuff. There's not a lot of time or room, but it's very important. Yes.
Oh, it's going to become more and more important, I think, as time goes on. So,
Yep. Okay. Good answer. Thank you. Heidi, if people would like to connect with you or learn more, what can they do?
the best way is to email me, I think. My email is Heidi, Heidi, Dalton, Dalton, 26 @gmail.com. Or they can go to the website, our ECLS Virtual Advisors website, and there are ways to communicate with us on there as well.
Okay. Excellent. Wow, this has been very interesting. Thank you very much. Thank you everybody for listening and watching. Thank you very much, Heidi Dalton, for joining me today. We very much appreciate you sharing your story and insights into impact and ECMO and healthcare in the modern times. Thank you.
All right. Thanks so much for the invite. Bye-bye now.
Inspired by our guests? Visit phoenixprosperitypodcast.com/guest and join us on the show and share your success story with Tim. The spotlight awaits.